Society's Ankara Spinal Days was done in our hospital, but due to COVID-19 pandemics this year, we will perform this online. First of all, this year we have a guest from Italy, Professor BASSANI. Soon I will introduce you him. But first of all, I want to remind you our mentor, Professor Dr. Hakan Caner, shortly. I will talk about his CV. He was born on 1959 in Ankara, Turkey. Was graduated from Hacettepe University School of Medicine on 1982. He successfully completed the neurosurgery residency in the same department between the years 1984 and 1992. He was awarded from both national and international societies for the studies in subarachnoid hemorrhage and vasospasm. He worked as research fellow in University of Virginia in Dr. Cassia's lab, and then he started to work in Başkent University School of Medicine, Department of Neurosurgery in 1994. He earned the degree of associate professor in 1997 and professor in 2002, respectively. In 2007, he was appointed as the editor of Turkish Neurosurgery Journal by the Turkish Neurosurgical Society. He provided that Turkish Neurosurgery Journal was indexed in Science Citation Index with his studies. His main interests were degenerative spine surgery, trauma, infection, and minimally invasive surgery, including kyphoplasty, MIS TLIF, and percutaneous pedicle screws. He was diagnosed as gastric carcinoma on 2011. He underwent surgery in Japan. He came back to work after surgery till the recurrence on April 2013. He passed away on December 18th, 2013. Dr. Caner was an exemplary academic with his hard work, scientificity, surgical skills, gentlemanly, and humanity. He has always been an example for the young surgeons whom he trained. With his personality, free from caprice and complex, he became a teacher and a brother when necessary for his residents. He has always guided his residents with the scientific research projects he planned, even in his hospital bed, and encouraged them to be scientific. I wish God's mercy on him and my condolences to his family and all his loved ones. First of all, I want to thank Professor BASSANI. I will appreciate him to accept our invitation in his busy schedule. Dr. Roberto BASSANI is the director of the second spine unit of Istituto Ortopedico Galeazzi in Milan. He is professor of orthopedics and traumatology at the university. He was born on 1965 in Italy. He was graduated from Pavia University School of Medicine on 1990. He successfully completed the exam to specialize in orthopedics and traumatology on 1997. Since 1998, he was dedicated to spinal surgery. He worked as visiting surgeon and attended clinical and surgical update meetings in spine pathology in several institutions. He completed vascular surgery training at Pavia University at Department of Vascular Surgery between the years 2005 and 2009. Since 2005, he has been teaching techniques for transforaminal lumbar approach, anterior lumbar and thoracic approaches, vertebral osteotomies in hands-on session on cadavers. He has given many lectures about revision surgery for failed back syndrome, minimally invasive techniques such as video-assisted anterior approach to thoracic and lumbar spine, non-fusion techniques in national and international meetings. His current interests are deformities, revision surgeries, degenerative disease of the spine, the development of minimal invasive techniques, and in non-fusion techniques. He has performed more than 4,500 major spinal surgical operations in cervical, thoracic, and lumbar spine, whether by posterior approach or anterior or posterior combined approach. Today, he will talk about anterior approach to the lumbar spine, indications, tips, tricks, and complications. Yes, Professor BASSANI, welcome.
Thank you so much, Hakan. Thank you for your invitation in this such important meeting of your society. Thank you so much. May I start with the presentation? You want?
Yes, please.
Oh, thank you. It's a real pleasure. I try to share my screen. Could you see?
Yes.
Okay. Okay. Sorry, I try to. Good. So my topic, and it's a very pleasure to share my experience with you that are experienced surgeon in your society of the anterior approach to the lumbar spine. I dedicated many years of my career to study of that because, as my colleagues say, I had the training in spine and vascular in anatomy. So I'm dedicated a lot to this kind of approaches. So the first goal when we do this kind of surgery, that means instrumental surgery, is to obtain a solid fusion. That means to see bone bridge. And the second goal of our surgery is to balance the spine. Every time we do an instrumented fusion, we need to fuse and to balance the spine. So it is very, very important to make a spine balanced. So for that, we have to know the morphotype of the spine. According to Rosoli, for example, there is no limit to the lordosis. Maybe normal small lordosis, as you could see in type 1 spine, or maybe normal to have a huge lordosis as type 4. So there is no standard lordosis, maybe different. And we have to know it because as spinal surgeons, we should understand that we can solve, we can improve a problem, but in some case, if we do a wrong job, we can create a deformity if we don't take in account a proper shape of the spine. So for that reason, we have to remember that the typical shape of the lumbar spine is this, and that we need the most important part of our lordosis in the lower lumbar spine between L4 and S1. So we have to remember every time the only anatomical parameters we need to understand how much lordosis do we need, that is the pelvic incidence. Even when we have a completely degenerated spine, if we know how the pelvic incidence is, we can understand how much lordosis we do need. So remember that we have a spine with high pelvic incidence, high lordosis, and we have spine with low pelvic incidence and low lordosis. So we have to take in account this issue, because if we have a high pelvic incidence, a huge pelvis, we have in the front, we face patients who are really able to compensate even a huge amount of hypolordosis. If we have patients with low pelvic incidence, they are not able to compensate. So probably this patient need to proper restoring a good sagittal balance. Because we know that with in elderly people, we have a narrowing of the disc and reduction of the lordotic spine in the lumbar part, and finally some compensatory mechanisms that are hypokyphosis in the thoracic spine, extension of the hip, and finally flexion of the knee. So how to reconstruct the lordosis? We use to put screw, to do some osteotomy, or to put cages. But when we put cages, it's not a simple thing. We have to take in our mind that if we put a posterior cage with a PLIF or TLIF technique in the posterior part, because we are not able to compress, so we cannot create a good lordosis. If different, if we put a TLIF like that, if different, if we put a cage, a short cage or a long cage, if we put a cage in the front and the back, because if we put a huge cage in the front, we can create a good compression posteriorly, and we can create a good lordosis locally. So the best should be a short Ike cage put in from the back in the real anterior part of the disc space if we do a posterior surgery. So we have different techniques to put cages. And it's different if we go in the front with the ALIF, if we go laterally, if we go posteriorly with PLIF or TLIF. And the powerful way to create a lordosis in going from the front, it's intuitive, because we cut the ligament in the front and we open the disc. So the better way, the best way to recreate a good lordosis is to go in the front. So the history of the anterior approach is so long. We published this paper last year because we have we start from a long time in the 30s of the last century. They try to describe the anterior approach using transperitoneal approach to reduce spondylolisthesis. And then we have no real improvement until the 19th, in which the minimal invasive technique improved a lot. And so we have the development of the retroperitoneal dissection and with better and better result. So the lumbar lordosis restoration finally is usually possible if you put a huge cage in the front, creating a good angle, opening the ligament and distracting the posterior facet joint, and getting a good lordosis. Sorry, there's something wrong here. Okay. So this is a case with a failed back surgery syndrome with a hypolordotic fixation without fusion, in which we try to recreate a good lordosis, putting two cages in the front. Just with that, we get a good balance of the spine. So why go in the front? Why anterior? Because we have a fusion in the weight-bearing column. We have get fusion at the center of range of motion with a great vascularity. We can cut the anterior ligament. We can put large implants with greater distraction properties. And finally, we can perform a complete discectomy and really clean the disc at all. So finally, this is the difference between a huge anterior cage and the standard posterior cleave. So we have a really big footprint of the cage, great primary stability. And finally, the result in thermal fusion is superior because we have a lot of bone ingrowth in that. So the main indication of the anterior approach are all the degenerative condition of the spine, mainly flat back associated, or in case of revision in non-junior or the infections. We have to remember preoperative risk factors to consider, and mainly body mass index. I do not suggest you to start with a very big man or woman because may be difficult. You need some experience to do that. Remember some comorbidities as arteriopathy, present of history of arteriopathy, arterial diseases, or in case of prior abdominal or retroperitoneal surgery, or previous anterior spine surgery, because you could have a lot of scarring tissue in between the retroperitoneal space and the bowel and the peritoneum. Those are many described the access for the space from the front. We do not use at all transperitoneal access because we just reserve it in very rare case of complex revision surgery from the front because of the incidence of complication, mainly ileum or retrograde ejaculation. So nowadays we use the transperitoneal only if we have large retroperitoneal scarring for previous surgery. So normally we go straight in the front in the retroperitoneal space. We don't touch the bowels like that. And we go through layer by layer through the retroperitoneal space until the lumbar spine. We just expose the vessels and a small part of the hypogastric plexus, generally the superior hypogastric plexus, we gently push away with cottons without using the monopolar. So we reduce the risk of retrograde ejaculation minus that 1% with this technique. So we are able to expose the disc, to cut the ligament, and finally to have a good exposure, a good opening of the disc, recreating a good lordosis. This is a specimen I prepared to show you. Generally, we can go medially or laterally to the rectus muscle, anterior rectus muscle. The first part is to identify the arcuate line that you can see here when you I took out the rectus muscle just to show you the posterior shades of the rectus. And just to show you that this is the discal 4L5, this is a specimen in which I show the lateral part of the disc. I took out the psoas muscle because I want to show the difference between the lateral approach that is right here in the lateral part of the disc through the psoas muscle, very close to the nerve root, compared to the anterior approach. This is the same picture magnified. This is the lateral approach. This is the anterior approach. You see here on my arrows the anterior ligament. So we go straight here, really medial, really straight on the disc. And we have to identify the vessel and the lumbar vein. I will show you later in a video. And so you have to prepare the vessel. This is the reason why you need some skills and some experience about general anterior vascular anatomy. If you need a single to approach to expose a single level, you can just do a single incision on the projection of the disc, for example, a funnel steel for 5.1, or close to the umbilicus on the navel for 4.5, or more higher if you need to expose 3.4. Or someone described a linear incision, some others lateral, in lateral position. There are a lot of paper describing different approaches for the lumbar spine. It's interesting again to show that with the anterior approach, you can expose the disc from L2, L3 to L5S1 straight. For L3, L4, you need to mobilize the vessel. For 5.1, this is the disc, the upper one is 4.5, the lower one is 5.1. If you need to expose 5.1, you just to clean the anterior part of the disc. You don't need to mobilize the big vessel, that means the common iliac artery and vein. And instead, when you need to expose 4.5, you need to go laterally and to prepare the common left iliac artery and vein to do that. Like that. This is the preparation for 4.5, and it's easier to prepare 5.1 because you go in between the vessel. What about the hypogastric plexus? Again, if you go straight through a retroperitoneal approach, 90% of the hypogastric plexus is pushed away with the peritoneum, so you don't see those situations. That is most common if you go straight through a transperitoneal. So the problem of retrograde ejaculation is really diminished with the retroperitoneal approach. The real enemy is the real concern is the left common iliac vein, because when you approach L4, L5, you have to prepare to mobilize carefully and to push laterally to expose the disc. In some cases, you find a big segmental vessel in 4-5, that is the ileo-lumbar vein. You need to identify every time to prepare and to push away to expose the disc 4-5. So you see, this is the 5-1, this is 4-5. If you need to expose 4-5, you need to mobilize the vein and the artery to be straight in the front of the disc. Really, with a good learning curve, it's quite easy and fast to get and to expose the disc L5S1. So it is important to have a good learning curve. Again, just to show you a short video, this is the incision for 5-1 we actually do. We incise the skin, then we cut the anterior fascia of the anterior rectus, the left rectus muscle. You see the left rectus muscle. We just, with your finger, do a blunt dissection. You check the epigastric, inferior epigastric vessel. Then you go really with your finger, easier, in the retroperitoneal space. You can see the artery, the arcuate line I will show you now, the artery, then the psoas muscle with the genitofemoralis nerve. You see here the arcuate line. This is the genitofemoralis nerve. This is the left common iliac artery. This is the psoas muscle, the rectus muscle that is lifted up with the retractor. You cut a little bit the fascia. This is the ureter. You gently push the ureter with your cotton. And finally, this is just to show you the anatomy. This is the common iliac artery, external and internal. And you see here blue, the vein. You just use the cotton, is very blunt dissection. You open the prosacral fascia, and sometimes you cut the medial sacral vessel and artery, and you are able to expose really easy the anterior part of the L5-S1 disc. This is the vertebral body of L5. I put the blade of the retractor and I fix with a pin. This is the right side. I just prepare the vessel. I put the pin to fix the blade of the retractor. You have a good exposure of your L5-S1 disc, really straight. You cut the disc, you do everything you want in this way, and now you prepare everything, and you can clean the disc and do everything you want. You take the disc out. It is very important because you can put a retractor in the front, open the disc, and working in the posterior part of the disc, removing all the material. And even if you need, you can open the canal, see the dura. We use a magnification with a camera to have a light, to have a magnification. This is a case in which we implanted this prosthesis, but generally the approach is the same for fusion. And finally, that's it. With multi-level, generally we use the perinatal approach. We described it some years ago. So we are able to expose up to 4 days from L2 to S1 with this one incision, because we just cut the skin around the umbilicus, the navel, and then we cut the fascia. We described this technique. We published in the EOS Master Series and on the paper. You can see here. And this is the projection of L5-S1 disc, just to show you that you can even expose 5-1 from the navel. You see the skin incision here. You just dissect the subcutaneous tissue. You do a sort of 270 degrees incision to expose the disc. Finally, you see the fascia. And you see the fascia here. And then this is the final positioning of the blade of the retractor. And you can see very, very well all you are doing, because we have the space to work, to take the disc out, to prepare the posterior part of the disc. You have the screen here in which your assistant, the scrub nurses, could see every part of the disc. You see very well how could you open the disc. That's the reason why the anterior approach is very powerful to open the disc and to recreate lordosis. You are able to open a lot to get a good posterior decompression, and finally you can put a big cage in the front with lordotic angle. You see the screen. We put in this case a 25 degrees anterior cage. It was a revision case in the front. You see the big cage in the front. You can put just screw or a plate as you want. And finally, it is very, very easy to put a plate, and this is the closure. Finally, in some case, I put a drain. And finally, this is the last step in which you reconstruct the subcutaneous and the navel. So you have the final incision like that. So you can expose up to 3 levels with that. So we published this paper some years ago. We are able to expose from L2 to S1 with retroperitoneal approach. This is the schema of what I show you. I don't go laterally to the psoas muscle, but medially. And then with my finger, I go deep and deep, 1 centimeter, 2 centimeters, 3 centimeters, 4 centimeters, 5 centimeters, 6 centimeters, 7 centimeters, 8 centimeters, 9 centimeters, 10 centimeters, 11 centimeters, 12 centimeters, 13 centimeters, 14 centimeters, 15 centimeters, 16 centimeters, 17 centimeters, 18 centimeters, 19 centimeters, 20 centimeters, 21 centimeters, 22 centimeters, 23 centimeters, 24 centimeters, 25 centimeters, 26 centimeters, 27 centimeters, 28 centimeters, 29 centimeters, 30 centimeters, 31 centimeters, 32 centimeters, 33 centimeters, 34 centimeters, 35 centimeters, 36 centimeters, 37 centimeters, 38 centimeters, 39 centimeters, 40 centimeters, 41 centimeters, 42 centimeters, 43 centimeters, 44 centimeters, 45 centimeters, 46 centi in the posterior part, and I put the blade like that to expose the disc. So those are the benefit, and this is the final position. This is the screen in which you could see all the procedure. I try to move, sorry. Okay, this is a case of 3 disc. You see the 3 disc, we approach with this approach. This is the incision. This is the projection of the disc. We start from 5-1, take out the disc, we open the disc like that. If you need, you can remove really a big disc herniation like you do in cervical spine. From the front, you can see very, very easily everything. You can see the root even from the front with the magnification. You see it, a huge big disc herniation. You clean the disc, you put the cage, then you go up from the same incision, you mobilize the vessel, you cut the iliolumbar vein. I just skip some step just to show you is the iliolumbar vein. You have to ligate it to properly expose L4, L5. This is the most difficult part. Again, you clean the disc, you put a cage, then you go up again. You see the third disc, and the final incision is this, the reconstruction of the navel. And this is the final scar. Then you go back, you put percutaneous, or you go open, you go what you need. This is the final intra-op X-rays. And this is the X-rays, and this is the post-op scar in tissue, 3 weeks, and finally at 5 weeks. So you see nothing. It's not aesthetical, the issue. It is that this is there's a small window in which you can go up and down to expose more discs, up to 4 levels. You can do it even for huge men. This is I did this operation in the US. I was invited 2 years ago in San Diego. We operated 2 big patients with 160 kilos, like typical American. So, and this was a good result. So now, someone in US start to use this technique and publish some result about this. This is a case in which we use a typical incision. This is a typical revision case. This lady was operated many years ago for scoliosis. She had a distal junctional problem with kyphosis, with 2 degrees of kyphosis, with an incidence of 49 degrees. So we need 50 degrees in the lower lumbar spine. So finally, or you do a huge osteotomy, or you put some cages to recreate a good lordosis. So we go from the front, and we put 3 cages from the front with lordotic cages again. And this is the result with a good result doing that. This is the pre-op, and this is the post-op clinical picture, and the perinatal scarring incision. Another case of, again, a distal junctional problem. Someone crazy tried to address it, inserting a interspinous device to address this kind of very imbalance. But finally, again, we need to have, again, 50 degrees. So we go in the front again, we put 3 lordotic cage again from the navel, reconstructing a good shape in the lower lumbar spine from the front, again, with a good fusion finally. You see finally the result of the numbers. This is the frontal, and this is the lateral view, post-operative, and finally the navel skin incision. Again, this is again a multi-operated lady in which we tried just to address the lower lumbar spine from the front without correcting all the spine. So we decide to go again in the front using multiple anterior cages. Again, we need to correct 42 degrees of the lower lumbar spine. We go again in the front and we put 4 levels cages in the front to correct the lower lumbar spine with this kind of result. Again, the cages. And this is the correction of the lower lumbar spine with a good balance because you see the reduction of the curl and the improving of the lordosis. This is the pre-op and this is the post-op. So this is just to show that even in adult deformity may be a good solution to put cages without opening the canal if you don't need to have a good correction, because it's very, very powerful going in the front. And this is the clinical picture of this lady. And this is the follow-up at 6-month follow-up. This is the novel. So this is again a 37 years old woman with 2 huge medial disc herniation with low back pain, persistent low back pain, and buttock pain. So irradiated to the buttock, in which again you need to take out the disc herniation, but even performing a fusion. So again, the anterior approach, it is able to make you able to address both the problem, to take the disc and the hernia out, and finally to put a good cage, anterior cages. And this is the final result. The CT post-op and the perinatal. So this is another one in which, again, with the spondylolytic, with the spondylo, which puts a huge anterior approach and percutaneous posteriorly. So it's useful even for spondylolisthesis or for huge imbalance combined with posterior and lateral. This is a typical 6'2" man with this kind of imbalance. He was not able to be straight. And you need, again, 60 degrees of lordosis, a huge correction. So again, or you do, or you perform big osteotomies, or again, you should use multiple cages. So we do prefer to go in the front and laterally to put cages and to recreate a good shape. This was the result after a combined surgery, anterior and posterior, anterior, lateral and posterior, where this is a 1-year follow-up. This was the previous clinical. This is again another case, a disaster, a multi-operated young woman for this idioplastic spondylo. She was operated with this kind of surgery. They just put 4 screws and a cage without reducing the deformity, because they did not reduce the severity index. There's no reduction, but just fixation. So she had the breakage of the screw. So the first surgeons tried to repair it with the second operation, but everything was broken. So it was a real disaster. She is just 52 years old woman. So if you manage the anterior approach, because we need to remove everything and create a solid anterior fusion, first of all, we need to reduce the deformity, pushing back L5 on S1. So this is the pre-op CT scan you see the ears machine X-rays with this huge hyperlordotic situation because of compensation. You see more than 100 of PI. So we need a lot of lordosis CS because it's just 72, but she has 100 of PI. So we start in the back first, removing everything from the back. Then we go in the front, put in 2 cages, 5-1 and 4-5, and third, finally, we put in compression. So first we go in the back, we remove everything, then we go in the front using a 30-degree endoscope and some special angled tools. We try to expose the disc to open. We need to find the previous cages, the peak cages. You can see here the cages implanted from the back completely subsided. We remove the cage from the front. We try to clean the disc up, the second cage. Finally, we clean the disc and we put a huge angled cage here, fixed with the screw. Then we go up on 4-5, we do the same. We clean the disc, we open, we put the cage. I just run to show you this part. This is the resume of the operation. This is the CT, the post-op CT. And then we go back in the same day. This is the same one-shot operation. The same day we go back, front and back. And this final X-ray, so the pre-op and the post-op. So you could see that with the use of the anterior approach and first of all, restoring a proper shape in the lower lumbar spine, you don't need to extend in the upper spine because we need just correct where the problem is, where the problem was. The problem was in the L4-S1. So we need to correct L4-S1, not to fix the spine at all more than those level. This is the pre-op and the post-op. So the multi-level perinatal alibi is feasible and reproducible, and it is spatial for multi-level. This is a case operated in the US in which...
So what are you doing here? You had surgery yesterday, yeah?
I had surgery yesterday.
A 3-level surgery made in the US with this technique.
You see you get out of bed.
The surgeon is asking to the patient, operated yesterday. This is the 1-day post-op. She is able to move and to...
Fantastic. And then tomorrow, why did you have surgery?
Lower back pain.
And we also identified
Scoliosis.
and spondylolisthesis associated with it. And how did we get to the front of you? How did we get to your spine?
It was through my belly button area.
Fantastic. Great. And tomorrow's back, right?
Tomorrow is back.
And tomorrow,
excellent. We'll get a video after
in the first day, they discharge from the hospital. So in conclusion, Alif produce a direct access anterior column, indirect compression, lower rates of neurological or dural injury because you go in the front. So there is a lot of paper publishing that Alif even has demonstrated high fusion rates because probably you have bigger cages and so you have a good primary stability. So for this reason, probably you have better results in terms of fusion. So a lot of other studies are showing that is a good option for degenerative disc disease. And probably we have a reduction of junctional problems. There are some papers that showing that comparing to PLIF, you have less complication and less junctional problems over time. 44% in the study of junctional problems using ALIF compared to 83% of PLIF. Probably again because you are able to get better lordosis, so the disc above is working better. And so Again, another study showing that and concluding that the ALF is probably preventing a adjacent second disease. A lot of study again showing that. I just skip this. I just showed the last study we published, again comparing CLIF and ALIF, and we observed on this study that we had less complication we discharged the patient in third day post-op, and we have a better results in terms again of fusion compared to CLIF. Thank you for that. And just a few words about complication, then I will stop my lecture because there are some complications. We have analyzed over 1,500 cases. We have some minor vascular injury, that means less than 200 millimeters of blood, and major bleeding. We mean bleeding in which we cut to the common iliac vein with more than 250 cc of bleeding. 7 cases over 1,500 of retrograde ejaculation, 1 recovered in 6 months, 6 retroperitoneal hematoma, 10 superficial 1 infection, 3 deep thrombosis resolved with heparin, and 1 dramatic ureter damage. Was a case of revision surgery, but we have to take in account. So are quite lower, and comparing to the general literature, we have the same level. So the overall incidence of major complication, vascular complication, was 2.7%, the same we observed in our experience. So this is a case in which we had the ureter lesion because she was operated, she's a girl, operated for L4, L5 disc prosthesis in another hospital. And finally, we had the mobilization of the prosthesis, and we should do a revision, removing the prosthesis, the total disc replacement, and put in a cage. But during that, because of the scarring tissue, we had the first left common iliac vein injury with consequent thrombosis, but moreover, 1 month follow-up just to check the deep venous thrombosis, we found a dilatation of the ureter and a dilatation of the kidney because of a stenosis of the ureter due to adherence for scarring tissue. And finally, she has an hydronephrosis leading to a nephrectomy. So this is a my complication. I had this kind of complication, this girl, and this very, very, I mean, heavy to have a nephrectomy in a young lady for anterior approach, but this because it was a revision surgery. And after this experience, I every time before a revision surgery in the front, ask to my urologist to put a stent in the ureter because I am able to identify and to protect here for a few days around the operation, because it is very, very easy to manage the ureter in revision surgery if you have a stent. So every time you need to revise from the front, please ask to put a stent in the ureter to protect it. This is another case in which when you plan a revision cage in the front like this was an infection. You see the abscess here and here. Okay, so we need to remove all the hardware from the front because of the infection. You can see here, I just again asked to put a stent in the ureter to protect it, and then to avoid lesion of the big vessels, you need to remember what are the possible concerns. We do have possible vascular lesion, yes, in this case, because this is revision. Ureter injury, yes. Sympathetic change injury, yes. So what to do? Prepare the vessel with the plastic bands, put the stand for the ureter, and be careful with the sympathetic chain. So use rubber bands. So with these tricks, we go from the front, put in the stand, we prepare the vessel with the rubber bands, you see, and then when I'm certain, when I'm sure to understand where the vessel are and where the ureter is, I can safely work to remove all the infectious tissue, to remove the airware, very safe because I protect the vessel. So this is a trick. When you do a revision, protect the vessel. Then you go in the back, you see again the infection here, back and front, and I remove everything to make the infection healed with a Staphylo. Finally, there's an insufficiency of the anterior column after a double X-leaf approach. The first surgeon was not able to put the cage, but prepared the disc in the lateral part for the X-leaf, but there was an accident, so due to a bleeding, so he did not implant the lateral cage here, but what happened, he had a breakage of the rods from posteriorly, so the only way to put a cage here is going in the front, because you see everything is broken. Chromocobalt rod, chromocobalt, double chromocobalt, but without the anterior approach, everything was failed. So you again go in the back and the front for a revision. First, we go back, we put a new chromocobalt rod, and then we go in the front. We need to put a cage here to have a good restoration of the anterior column, anterior support. So was a mismatch between the disc due to a spondylo. So we just to prepare precisely a short cage in the front. We see here all the scarring tissue because you know that the first surgeon trying to go laterally, so we have scarring tissue here. So we just go in the front. So we prepare in the front the vessel again. You see here all the scarring tissue. We prepare the artery, the vein. We find the space, the interdiscal space. We try to clean the space here in the front. Then we prepare step by step the disc space. You see the posterior part of the disc space here. We put a cage. You see the intra-op X-rays just in the anterior part, a small anterior cage. And finally, we are able to reproduce a good anterior support. And this is the final X-rays, final CT with fusion. And again, the anterior support here and the final picture of the patient. So again, and the last useful of the anterior approach, just to show you the end of this. Finally, the surgeon put a cage in the front with lateral approach. I will show you this picture. So the first surgeon put a plinth that was pulling back in the canal, and he tried to put a lateral cage to have a good support, but was not able to remove the posterior cage. So the patient had two cages, one in the lateral that was mobilized in the front, and one in the canal because of the mobilization. This is the impressive MRI, you see. So we have in the condition to remove the lateral and the posterior. You see the vessel, this is the vein pushed in the front by the cage. This is the artery. So the only way to address this complex situation is go straight in the front, mobilizing the vessel, take the cage out, and then take this cage out. So again, the anterior approach is the only way to do that safely. So take in account this kind of complication. For minor bleeding, just compress. 99% of minor bleeding stop with compression, using Flocil, sometimes bipolar, and so on. In major bleeding, again, a good percentage of that stop with compression, or in some case you use hemopatch or suture or clips. And finally, you compress again and use Flocil. You need again to have a good anesthesiologist, a good spinal team with cell saver, and all you need to be prepared to impressive in a short time bleeding. So please, the worst enemy, it is only panic. Don't be in panic, and if you need a rescue vascular surgeon, I am a vascular surgeon, so I do it. But please, when you do this kind of surgery, you should have a rescue vascular surgeon to help you. It's not a problem. It is not a problem, the artery, because you see every time, and you can use bipolar or sometimes use a direct suture. The worst enemy all the time, the vein, because as I will show you, when you prepare, if you are in trouble, prepare the vein with this rubber. So when a bleeding occur, is a sample to show you, you just put your finger and you close your rubber bands, and you are able finally to prepare the vein and to apply your suture to solve the situation. That's it. Thank you for attention, guys. Thank you. If you have some question.
Thank you, Dr. Bassani. It was an excellent presentation. Since anterior surgery is not so common among neurosurgeons in Turkey, so it was very good to see and to learn from your experience. I'm asking for the participants if they have any questions. We have a question from Dr. Harman. He says, thank you for your excellent presentation. In L4 and L5 osteomyelitis case, is it possible to perform anterior L4 and L5 total corpectomy by this perinaval approach? If not, which approach do you prefer? Anterior transperitoneal or again retroperitoneal?
Yes, my answer is yes, because the anterior approach using the perinaval make you easier possible to use this navel, this opening, this as a sliding door, so you can go up and down. It is very important, it's mandatory to have a proper retractor, and there are special retractors on the market to do that with blade. So you can put blade, you can put the light inside, and so you can see very well. So yes, you can do a corpectomy with this approach because you can move the skin up and down. And if you need, you are in real trouble, you can open more a part of the ring of the incision, so you can open if you need. You can do that. We don't use anymore the transperitoneal for the reason I declared before, because you have a lot of complication, and with the retroperitoneal approach, standard or using the perinaval, you are able to go straight to the spine for each level from L2, L3 to L5S1.
And we have one more question. Dr. Kanat asks, He thanks for the presentation, and he says 60% of your patients are females. What can be the reason of this female predominance?
66%, no, in the paper 66%, but generally there's a reason, because we have 44% in that paper of male, but as I show you, we have just 7 retrograde ejaculation. It is a case, but generally we don't care about that. We always speak about the possibility of retrograde ejaculation with men, but really believe that if you use a proper technique in retroperitoneal, you have to avoid monopolar, you have to avoid bipolar, just use cotton, because we have the habitude to read the paper, the old paper in which the general surgeon or vascular surgeon make for the spinal surgeon, neuro or ortho, the standard anterior approach transperitoneal. So they don't care about the hypogastric plexus, because I am a vascular surgeon. My goal as vascular, when I have to treat a non-aneurysmatic dilatation, is just to save the life of the patient. So I don't care about the plexus. The reason why they don't have all the tricks to save the hypogastric plexus. There are some paper demonstrating that. So if you use a proper technique, the risk of retrograde ejaculation is very, very low, less than 1.5%.
And Dr. Bassani, thank you. And I want to ask you something. When I was fellow in Galeazzi, I see that the Italian people's reactions are similar like Turkish people's reactions. And what do the male patients react? How do they react when you tell them about the risk of the retrograde ejaculation?
Yes, I actually speak about the real percentage of the risk that is very, very low. Generally, you have been here in my institution, and you saw that we did a lot of anterior approaches, and every time we speak about that. So if you identify a really motivated patient, that means very, very painful, because remember that when we operate a patient for low back pain, we really select the patient that he tried every kind of pain therapies, painkillers, and other therapies. So they are really motivated first. And then I just try to weight pros and contra. I say, okay, you have the risk of 1.5% to have a retrograde ejaculation, but probably this minimal invasive technique is very powerful for your problem. Probably we gave you really an improvement for your back pain with a minimal invasive, with the prompt recovery. So they try to balance risk and pros, and they accept 95%, they accept this. And someone, not more than 5%, give the spermatic fluid for the future, just 5%.
Okay. And we have one more question. Dr. Herman says, do you get any assistance from vascular surgeons? But maybe he didn't catch that you already also a vascular surgeon.
Yeah, but generally you should have a rescue when you do that in practice, yes, if you are not able, yes.
Okay, and I want to ask you, do you perform stand-alone ALIF in your patients without posterior support?
Yes, we do a lot if we have in front just in a degenerative disc disease. If I don't need to open the canal, but just I do it indirect decompression, I always do just pure anterior cage with screw or plating. I put cage in the back when I need to open the canal or when I need to compress to create more lordosis. Anyway, I do just in the front.
Okay. Thank you. We have also one more question. Do you change your surgical plan for osteoporotic patients? Is there any problem to subsidence or telescopic effects of cages?
Remember the main, you are all, I think, a skilled surgeon, mainly posterior surgeon, and you know that when you have an osteoporotic patient, in many cases, you could have a subsidence of the cage from the back. But if you think the size of the cage may be intuitive, that if you put from the front a bigger cage with a bigger footprint, preparing the disc, avoiding to damage the end plate with big cage in from the front, you reduce the risk of subsidence because you use the ring as holder of your cage. So my answer is you reduce the risk from the front because you have larger implant.
Thank you.
Even in osteoporotic patients.
And I want to ask you, do you experience any wound problems in perinatal incisions?
Yeah, I show some complication. We have 10 in superficial infection. We have 10 superficial infection. That is, I don't remember the percentage in this paper. Now we operated many more that in the patient of this group, but in this group we analyzed, we have 10 infection that is around 10% in the first group that we diminish a lot because we don't suture in tension the skin, so we reduce the dose. In the first cases we had more, but generally even for multi-level because you pull the skin up and down when you go multi-level. In some cases you can injure the skin, but again with a good learning curve over our patient, we learn to better treat the skin and not to suture in tension, so we reduce the skin problems. Anyway, now we had a low percentage of skin problems. Yes.
Do we have any more questions? And what do you think about XLIF?
We do, you know that we do a lot of that when we need to correct multi-level degenerative scoliosis. I think that the lateral approach is very powerful because you put large cage and you are able to correct the coronal plane. The difference, the main difference is with the anterior approach, we cut the anterior ligament and I use it when I need to recreate a local lordosis or to redistribute a good lordosis where I want to do. Because you could be very precise because I can use 20 degrees, 25 degrees, 30 degrees cage in a 4-5-5-1 because I'm in the front, I'm straight. I can do what I want. With lateral approach, you don't cut the ligament. Even if you put a lordotic cage, you are not able to control how much you need. So that is the reason, but we use a lot, is our first choice for coronal imbalance in degenerative scoliosis. A very, very good technique.
When the problem is sagittal imbalance, you prefer ALIF. And when the problem is the coronal imbalance, you prefer XIF.
Yes, or in many cases, I show you a case, I use both. For example, I need 40 degrees in 4-5-5-1. I put one cage in 5-1, 25 degrees, one cage in 15 degrees in 4-5, and then 3-4 to 3-1-2. I need just the anterior support, or to correct the coronal, I put lateral. I go laterally. I try to combine. It is important to have a lot of weapons, anterior, lateral, posterior. If I, for example, if I need just to decompress the canal because I have osteophytes, nerve root compression, I put leaf because I go in the back, I'm just decompressing, I put a leaf here. If I don't need to have a good, I don't need a lot of lordosis, I go from the back, for example, and I put a cage, a huge cage in the back with a cliff technique, really anterior, a high cage, and I compress from posterior if I don't need 20 degrees. If I just have, I need support, I need to decompress and I needed 5, 10 degrees, I put a clip, for example. I use all techniques, depending on the problem is. But to me, it is very important to plan a proper preoperative strategy. It is mandatory to reduce our complication. And since when we did that, we reduce post-operative revision case. We have a lot of revision case, but we reduce trying to reproduce a standard algorithm of making decision.
Yeah, thank you.
Thank you.
If we don't have any questions,
may I thank you? May I just conclude? I'm really honored to be with you, because when Ekrin asked me to participate to this meeting, I'm honored because I'm honored to participate in your meeting more and more, because I have the opportunity to give this lecture and to share with you my experience. I know that all you are a very skilled surgeons, so thank you very much, Eric, for this. For me, it is an honor that I bring with myself. Thank you so much.
we thank you. Thank you for the presentation. And we are looking forward to see you in Turkey, maybe after COVID.
Maybe.
In our...
yeah. Again, I will be honored if you want to join you, even to learn everything you have to show me, because I'm so curious, and I think that every one of us have to learn from each other every time. I learn a lot from everyone meet me and so on, because every one of us have a good idea that have to think. Thank you so much again.
Exactly. Thank you.
Have a good meeting. Thank you.
Thank you.
Thank you. Thank you.
Ali abi, toplantımızı bitirebiliriz.
Çok teşekkür ediyoruz. Ellerinize sağlık.
Biz teşekkür ederiz. Tekrardan Hakan Hoca'nın anısına yaptığımız bu toplantı için çok teşekkür ederiz. Türk Nöroloji Derneği'ne de. Tekrar görüşmek üzere.
Görüşmek üzere. İyi akşamlar. Selamlar. Çok teşekkürler.
İyi akşamlar.
Görüşürüz.
En çok yaşadığımız şeylerden biri şüphesiz soğuklar. Şimdi hepimizin kafasına takılan bir soru.